Hi there, good evening everyone. I hope you can all hear me. And welcome to our first echo session of our Enhancing Palliative Care series. Okay. So this session tonight will focus mainly on symptom assessment and management, part one. It's such a huge topic and we'll be joined by our presenter shortly, Dr. Olivia Gregorowitz. Firstly, starting off, I'd like to acknowledge an acknowledgement to country. We acknowledge the Kaurna peoples who are the traditional custodians of the Adelaide region, and we pay respect to their physical and spiritual connections to land, water, sea and community. Enduring now, as it has been throughout time, we pay respect to their culture and to elders past, present and future. We would also like to acknowledge and pay respect to those Aboriginal and Torres Strait Islander people from other nations who work, travel and contribute on the Kaurna country. So, welcome to the Palliative Care Echo Project. The Palliative Care Echo Project is a 12-month initiative to cultivate communities of practice and establish continuous professional development and networking among GPs and palliative healthcare providers across South Australia who care for patients with life-limiting illnesses. If you haven't had a chance already, just pop on our GP Partners website, www.gppaustralia.org.au, and we do have a dedicated page to our Project Echo. So please, when you get time, pop on and have a look. So first of all, thank you. This project is supported by funding from SA Health through the Palliative Care 2022 Grants Program. And the project is being delivered to you by GP Partners Australia. So what is Project Echo? Project Echo, which stands for Extension of Community Health Outcomes, is a virtual knowledge sharing network designed to create a learning loop between health professionals with the aim of increasing knowledge and access to healthcare in local communities. So a little bit of housekeeping before we get the session underway. So please introduce yourself in the chat. Let us know where you are joining from and your role. Your microphones are muted. That doesn't mean that we don't want to hear from you. There'll be lots of time during the session for questions and discussion. We encourage you to turn your cameras on, as this will help make our session much more engaging. You're welcome to use the chat function to ask questions if you have any comments or having any technical difficulties, but also feel free to just raise your hand. The didactic session will be recorded and will be emailed to you within the coming week. By participating, you indicate your consent to recording. The case study, however, will not be recorded. Remember not to disclose any personal health information during the session. Finally, these series are undergoing accreditation through the RACGP and ACRM, and we really hope that you do enjoy the sessions. So how Echo works, the general format for our session will be that you will start to notice that each of our sessions follow the same basic structure. We will start off with a brief introduction. We will then have a presentation by one of our subject matter experts, followed by an interactive case-based discussion by one of the participants in our audience. We will then have a brief session wrap-up. One of the key ingredients of the Echo model is that they are interactive case-based discussions. So we really encourage you to consider presenting a clinical case during one of our upcoming sessions. And I know that I've sent out the template to you numerous times, but please, if you can provide us with a case, that would be great. By presenting a case that is currently a challenge, you get to tap into the collective wisdom of this community of practice for advice and support. Bringing forward your own cases can help you feel more supported by your peers, who can provide reassurance and advice that is geared to you. Cases can be either active or historical. They can be based on actual cases or a combination of cases. Your case does not need to be complex, but on the other hand, it could be quite challenging. If you would like to submit a case, there are several ways for you to let us know. You can either simply let us know in the chat at any point during this session, or you can email me at lmarch@gppaustralia.org.au, or you can let us know when we send out our feedback survey. So by now, you all, with registering, you would have seen the overview of the session. We have 9 in total, and pretty well will be 1 a month, except for over the Christmas period. And the first session tonight is 1 of 9, as I've said, which will span until the 12th of April next year. Today is our first session on symptom assessment and management, part 1. And as you can see, we'll be covering a broad range of topics over the coming weeks and months. Our hope is there will be an opportunity to hold even more sessions with additional topics that will meet your learning needs later into next year. While it is not a requirement that you attend each session, we do encourage you to attend as many of these sessions as possible, so that we have the opportunity to get to know each other and collectively build off the learnings from one session to another. So some introductions. As you know, I'm Leanne and I'll be facilitating today's session. Unfortunately, it was meant to be along with Dr. Russell Shute, who is our GP advisor and lead GP with this, the co-clinical lead. But he unfortunately has come down with a cold and has a sore throat and has laryngitis. So we couldn't even get him to join remotely. So tonight I hope I can do him justice by presenting on his behalf. So I'm the General Manager here at GP Partners Australia and also the manager of our GP shared care programs. I'll just take a brief moment now to turn over to the rest of my panel so that they can introduce themselves.
I might start. My name is Olivia. I have recently completed my palliative care training and I'm in a bit of a transition phase. I think it's going to probably take me about a decade to own up to the title of specialist. But it's really lovely to be able to be part of this program. I initially trained as a GP, and whilst my basis of palliative care is sort of within a tertiary setting, I'm so excited to be able to learn from all of you and see how you manage sometimes some extremely tricky patients in your clinics and in your networks. And I think maybe even some people joining us from the country, which is an experience I don't have. So it's so nice to be able to, I guess, learn together.
So hello all, my name is Julian. I am a pharmacist and I work as an embedded aged care pharmacist at a nursing home in Tanunda in the Barossa Valley. And what that means is that I'm on site 3 days a week, which is a little bit different than the usual model where the pharmacist is contracted and visits occasionally. So as part of my role there, and with some grant money from the PHNs, we've established some palliative care support programs for the GPs in the area to sort of enhance the palliative care in aged care homes. I also work at Flinders Hospital with Olivia as a palliative care pharmacist, supporting them on a project which has involved expanding their service and providing more palliative care for patients at home. GP collaboration has been a really key element of that, and I'm really excited to speak with you and hear all from all of you about what does and doesn't work, particularly when we're talking about the interface between patients returning from hospital and palliative care in the community.
Hi everyone, my name's Naomi. I work for GP Partners Australia, and I am the network coordinator for ECHO, and also do the website development.
Hello everyone, I'm Atif. I'm providing IT support for ECHO. So if everything goes right tonight, that's my credit. If everything goes wrong, that's your device and that's your internet connection. Okay, back to you, Leanne.
Thank you. Okay, so that's us. In coming sessions, we might call upon you to introduce yourselves, but for tonight, I think we will keep to the agenda. And so now I will hand over to Olivia for her to present her presentation.
Lovely, thank you, Leanne. I just need to pull up my presentation.
Would you share the screen?
I know I'm gonna share the screen, I hope. And
Oh, good.
all right, perfect. Now I feel like I possibly started halfway through. There we go. So I was tasked to give a presentation about symptom assessment and management of palliative care symptoms in 20 minutes. And I have sort of been thinking about how to tackle this task, which is, you know, a huge topic. And really, I would love some feedback about if I've taken, you know, a route that is possibly covering things that you possibly know, and if I've pitched things in a plane that you might need me to change. So please do give me some feedback, and we have another session on symptom management. So love to cover the things that you're really particularly interested in and wanting to know. Certainly, if I was to divide symptom management, you know, there's so many ways I can think about this. And is it malignant versus non-malignant symptoms, or is it body symptom based? You know, we could talk about respiratory symptoms, neurological symptoms, gastro, skin, genitourinary diseases. We could talk about palliative care emergencies such as bowel obstructions or seizures or core compressions or pathological fractures. We could think about diagnosis-specific symptoms pertaining to people with dementia or renal failure. We could talk about symptoms specific to the terminal phase. However, what I have chosen to do is talk about the common symptoms that the majority of our patients have an overlap. These common symptoms include pain, delirium, dyspnea, nausea, anxiety, and fatigue. And I've included here a screenshot from a study, which is an older study by Solano, shared, I think, quite a few times, but shows the comparison of symptom prevalence in advanced cancer. And you can see that these symptoms occur with quite a high prevalence. When I think about managing symptoms, I like to think about a bit of a sieve and think, is the symptom that my patient presenting with as part of their disease? Is it indicating that their disease might be progressing, or is it a complication of their disease? Is it related to treatments that they might be having? And this is often the case in patients who might be undergoing chemotherapy or radiotherapy. Is their symptom a manifestation of their psychosocial suffering? And we all know that there's a complex interplay between the physical, emotional, and spiritual and social domains of our patient's life. Of course, and you're probably better equipped sometimes than we, who have sometimes a specialist lens, but thinking about, is it an unrelated condition that is occurring in a patient who does have a different terminal diagnosis? And very much, if I think about the management of a patient in palliative care, it's always trying to tailor the treatment to be goals focused, and specific to what the patient is hoping for. In palliative care, we often use a symptom assessment score, and we're meant to check these particular symptoms in every patient review that we do and think about difficulty sleeping, appetite problems, nausea, bowel problems, breathing, fatigue, and pain. I thought it might be helpful to have a bit of a picture of a patient in our minds, and it won't be a particularly complicated patient and someone that you have definitely met before. In the interest of trying to be brief, I've scaled down the case a little bit, but I want you to think about Jane. And Jane is 63. She is married and she has a son and a daughter. She's been diagnosed with breast cancer almost a decade ago, and she had a lumpectomy and axillary clearance at that time. She underwent adjuvant chemotherapy and radiotherapy because she had some positive nodes. She's got some comorbidities, including type 2 diabetes and non-alcoholic fatty liver. She's come to see you and she describes a 3-week history of pain. It's right chest wall pain and in her mid-back. It's constant in nature and it's exacerbated by movement, and it's waking her up at night. I think appropriately you're all thinking, is this progression of her disease that she's been diagnosed with, and a chest x-ray confirms that she's got new metastases in the site of her 6th rib and also in her T5 vertebra. Undergoing a bone scan, we can see that Jane has widespread bony metastases. If we think about her symptom of pain, I don't particularly want to do a whole presentation on pain. I think we could speak hours and hours about a really complicated topic. And so I'm just sharing a small snippet about how I sort of a basis of prescribing for palliative care patients and sort of the way that I approach things. We're all familiar with the WHO analgesic ladder. And whether or not this has gone a little bit out of fashion, I think Julian, our pharmacist, might have some ideas about that. But what I do like about the analgesic ladder is that it always prompts us to think about non-opioid options and also adjuvant options. I think we see the term weak opioids and strong opioids a little bit. And certainly in my practice, I tend to avoid the medications in the class of what we call weak opioids. Why I think in palliative care we often tend to ignore these medications is we see that they often have a bit of a ceiling effect. And specifically, if we think about tramadol, there's always risks of interaction. I also tend to avoid the prescription of a patch because there is always difficulty in titrating doses of patches, as there's always a slow time to reach steady state, and dose changes always comes in quite large intervals. And then I think about the strong opioids, morphine, oxycodone, fentanyl, hydromorphone, and methadone, which is possibly more of an opioid adjunct. And this is generally where I tend to prescribe from. And really, if I think about choosing an opioid for any patient, I think about, do they have any contraindications? Do they have any allergies? And is there anything limiting the route that they can take the medication? And I think for Jane, she doesn't have any of those limitations. Her renal function and her liver function is not impaired. And I think a reasonable choice is to commence Jane on regular paracetamol, which is quite good for bony metastases, and also a smaller dose of morphine syrup at a dose starting at 2.5 to 5 milligrams every hour as required. And in prescribing for a palliative care patient, especially a patient with malignant pain or pain secondary to a cancer, my general way of starting is to prescribe an immediate release opioid in order to titrate and to work out what that patient's background opioid load might be, or what their opioid need is, I should say. I always encourage people to keep an opioid diary, and appropriately you you or myself, we've decided to review Jane 3 days later. She's been using her morphine syrup. She finds it effective, and she's used about 4 to 5 doses a day, and she's found that that's keeping her comfortable. We can add that up and see that she needs about 20 to 25 milligrams of morphine in 24 hours, and it's appropriate to commence her on a long-acting opioid, and MS Contin 10 milligrams BD would be a reasonable background that we've established her to need. Let's skip forward 1 month later, and there's been a little bit of titration of her pain requirements over time, and she's now on a dose of MS Contin 30 milligrams BD. She is finding, however, that that initial dose prescribed of 5 milligrams of morphine is just not quite effective anymore, and that brings us to think about breakthrough dosing. So breakthrough dosing is that immediate release dosing. And sometimes we're all guilty of it, but we forget that over time, as the background analgesia increases, we need to consider the appropriate dose of a breakthrough dose. Roughly, the guideline is a 12th to a 6th of the daily background dose, charted 1 hourly PRN. And very much if a patient is comfortable on that dose, would sort of say that we're in the right ballpark. If they're really finding that they're still needing more and more of our immediate release breakthrough pain during the day, we probably haven't quite got the background right. In practice, I probably use a range of a 10th to a 6th, as I find the maths a little bit easier. I think just one other small point to talk about opioids. If we think about Jane, there might be a point in time where her regime is just not quite working anymore. We've tried to escalate the dose, and she's just not finding the increase to be as effective as it used to be. In these situations, we might consider switching opioids, and we will consider this if there's any adverse drug effects experienced, if there's any changes in renal function, meaning that that medication might be contraindicated, or liver function, and particularly for morphine, we always think about renal function as it is renally cleared, or maybe, and possibly not for Jane, but your patient might actually lose the rate of administration. They might not be able to swallow the tablets anymore, and they might need a different route. And there might be this sort of sense of wearing off, or the opioid not being as effective, and we might think to switching to another opioid. And opioid rotation is not an exact science. There are many guidelines and tables, and also apps that can help you work out the equi-analgesic dose of one opioid to another. However, given the broad range of what different different conversion guidelines will recommend, you can see that it's not quite precise. And it's always safe to reduce the dose of an opioid if you're changing from one to another by 25 to 50%. In practice, we do this as a team. It's tricky, and there's always a bit of safety in calculating it yourself, getting someone else to check on your team, then getting our palliative care pharmacist to check. And then I might even plug it into one of my favorite apps just to make sure I've done the maths correctly. And we would always be happy to take phone calls and guide this process if you feel that it is required, or to review any patient as required. Not sure if you have a bit of a sense of it, but if we think about oxycodone, 20 milligrams of oxycodone is equivalent to about 30 milligrams of morphine. They're not quite dose equivalent. Hydromorphone, 6 milligrams is equivalent to 30 milligrams of morphine. Just a quick word about fentanyl before we move on to a different symptom. But fentanyl, the bioequivalence of a fentanyl patch to oral morphine is, I think, one of those that are debated the most and has the broadest range of what people think is the bioequivalence. Some guidelines will say a fentanyl 12 microgram patch is equal to 30 milligrams of oral morphine, but there are guidelines that suggest it's equal up to about 60 milligrams of morphine. And thereby, this is quite a high starting opioid dose, and it's suggested to never start a fentanyl patch in someone who is opioid naive. I don't want to speak about adjuvants today. I don't think we quite have the time, but if there's a feeling that there's neuropathic pain involved, an adjuvant is often a good option to add into the mix rather than just escalating opioids. With Jane, on diagnosis of her bony metastases, she was referred to medical oncology and radiation oncology, who were able to provide radiation to that rib lesion and the T5 vertebra, and with the hope that a change in her chemotherapy treatment will provide a bit of control over her disease and thereby her pain. I think we're sometimes not very good about thinking of other things that can help manage pain, including massage, hypnosis, meditation, acupuncture, and relaxation and aromatherapy. Also, something that might be opioid sparing is intervention, such as regional nerve blocks as well. Moving on, our patient Jane. Oh, sorry, I clicked the wrong thing.
Stop sharing.
Oh, I've possibly stopped sharing my my
Yeah.
screen.
It actually cuts you out.
And I'm so sorry. There's always got to be some technical difficulties.
Problem again. So she dropped out, which is
Yeah. All right, now I know that constipation is something that you're probably well able and well used to managing in your broad patient population, from children to your patients in nursing homes. But certainly it's become a problem for Jane with the opioids that we've prescribed, and she has firm stools that she is moving every 2 to 3 days, which is a change for her. When I think about constipation, it's multifactorial. It's slow intestinal transit time, it's poor oral intake, it's poor hydration. Opioids absolutely contribute, and also our anticholinergic burden and our serotonin antagonists such as ondansetron and generalized weakness all contribute to constipation. Essentially, when I prescribe an opioid, I prescribe an Aperian, and our favorite our starting favorite is Caloxone Senna, 1 to 2 tablets twice a day, and always thinking about having an osmotic laxative as a second line. Sometimes we do need to escalate this, and we think about suppositories or larger enemas, or even a bit of a Movicol bomb is sometimes helpful. Certainly, I do a lot of PR examinations for patients who might be constipated, and sort of hard stools in a rectum might change my management compared to maybe having softer stools, which might need more of a propellant suppository such as bisocodyl. Finishing up our discussion about pain medications, I just want to quickly talk about Targen. I'm possibly talking a little bit slowly, but Targen, it's a combined medication, prolonged release oxycodone and naloxone. And you just want to stress that it's contraindicated in moderate to severe liver dysfunction. In a patient with normal liver function, naloxone antagonizes the effect of oxycodone in the GIT. It's removed by first pass metabolism by the liver, and thereby it doesn't affect analgesia. However, in a patient with abnormal liver function, and this can often be our patients with cancer that readily metastasize to the liver, they will have impaired first pass metabolism. And this means that the naloxone bypasses that first pass metabolism and ends up in the systemic circulation, leading to poorer pain control, poorer efficacy of PRN medications. And there are a few case studies of where patients are swapped from Targin to another opioid. We can cause narcosis due to the peripheral use of due to the systemic use of the naloxone. And then actually what they're absorbing is much lower than what is actually being prescribed. Moving on from pain and constipation, Jane comes back to see you and she's nauseated and she's vomiting. It's some months and her disease is progressing and the sight or the thought of food is problematic. Like lots of our symptoms in palliative care, I always like to think about what is the underlying cause. Is this actually a problem that I can reverse and completely manage? Or is this just a symptom that I need to treat and provide a bit of benefit, symptomatic relief for? Certainly, if we think through our history taking, thinking about is nausea persistent or is it intermittent? What is actually coming up? Is it undigested food? Is it bile? Is it feculent vomiting? And what is the timing of the vomiting? Is it around food or is it possibly in the morning with some postural association? And is there any associated symptoms like any new neurological signs? Certainly there's things that are easier to treat and easier to reverse. And these are things like constipation. It might be gastritis, which we can help with a PPI. It might be some metabolic issues, and hypercalcemia or acute renal failure are often abnormalities that we can treat. Other things you'd expect to pass, like side effects from chemotherapy or radiotherapy. However, there are lots of reasons for nausea that we can't particularly treat or reverse completely. I always tell my medical students that the pathology in palliative care is quite impressive and amazing, and to examine patients as much as they can. But here we can see a large cerebral met with swelling. We can see a large liver, huge burden of metastases that might be compressing a stomach, causing nausea. This volume of constipation is quite frightening to me. That's caught on a CT scan. In the middle, we've got some dilated small bowel, and then on the end, we can see a huge volume of ascites in the abdomen and in the pelvis, with sort of all the organs swimming in the middle. I think as doctors, we sometimes tend to forget the non-pharmacological measures and avoiding triggers, avoiding smells, encouraging patients to eat small meals, snacky meals throughout the day rather than sitting down to regular large meals, limiting medication, and possibly Julian can speak more about this, but de-prescribing for our palliative care patients can add quite a lot to their care. Do they have candida? Do they have poor oral hygiene? Is there a role for ginger? I'm not quite sure. But for some patients who might have anxiety affecting the sensation of nausea, is there breathing techniques or relaxation techniques that can do? And for our patients with fungating wounds or stomas or ulcers, managing smell will help their nausea. So if we think about which antiemetic to pick, I think metoclopramide and haloperidol score the number 1 and 2 position for what is shown to be our prescribing preference. But I think very neatly, and I'm really sorry about this very busy slide, we actually bring it back to our physiology of how the brain causes the stomach to vomit, causes the lower esophageal sphincter to relax, causes contraction of our diaphragm and our stomach to expel gastric contents. It's quite intricate, and it helps actually guide our antiemetic choice. So certainly, if we think about our triggers, is it abdominal distension from the gastrointestinal system? They have serotonin receptors. Is it the chemo trigger receptor zone? Sorry, the chemoreceptor trigger zone. I'm getting my acronyms mixed up. But this is a zone in the brain which actually sits outside of the blood-brain barrier, which picks up all the toxic changes in the blood, uremia or hypercalcemia. And the receptors there, we've got serotonin receptors and dopamine receptors. Is it a vestibular cause? Do we need to think more about histamine receptors or our muscarinic receptors? Or is it the cerebral cortex sending us signals of fear and anxiety via the serotonin and GABA pathways? If we think about these receptors, we can have a bit more of a nuanced pick about which antiemetics that we can prescribe. And I've just provided a little bit of a guideline there, and it's not gospel. And I think nausea is actually one of the trickiest symptoms I find to treat. And some patients, they just have intractable nausea despite multiple agents being used. But certainly, I think if in doubt, what my default would be haloperidol. If we're thinking about sort of drug-related nausea, haloperidol or levopromazine, working on those dopamine receptors is probably useful. Chemotherapy or radiotherapy, you'd see your patients having a lot of ondansetron, and certainly that's where the PBS listing is, but dexamethasone might be helpful as well. Antihistamines for our vestibular causes, metoclopramide for our gastric status, noting that metoclopramide is a prokinetic and might get the gut moving. It is, however, contraindicated if we have a full obstruction, and it will actually cause more cramping, pain, and haloperidol or cyclizine with some steroid will be a better option. We mentioned gastritis before, adding in a PPI, and certainly if we're thinking about CNS disease, dexamethasone or cyclizine is a good idea. And thinking about our benzo class or other anxiolytics if patients are very anxious. Just to finish up my presentation today, and I really apologize if I've taken a little bit too long, but let's imagine that it might be a year or 2 years down the track and Jane's disease is progressing despite multiple lines of chemotherapy, and she's come to the decision to stop her treatment. Her function is deteriorating, she's fatiguing, and she's having progressive shortness of breath walking to her bedroom. When I think about dyspnea in palliative care, there's lots of causes, especially for our patients with malignancies, and often these are non-salvageable, and our medications or our treatments are of limited benefit. We think about the patient with hugely rampant disease in their lungs, huge burden of metastases. Would a little bit of dexamethasone help reduce periedema? It might, but it probably won't help. Does our patient have a huge volume of carcinomatosis, lymphangitis? Will that steroid help? It might temporize for a very short period of time. I think cancer patients, they can throw up all sorts of different things. And here I've got a picture of a pericardial effusion. Could a drainage help? It might, but it's a very poorly prognostic sign. Does a patient have a PE? Should they be anticoagulated, or are they a candidate for their thrombolysis? And certainly if a patient was extremely frail, they would unlikely be an appropriate candidate. Or do they have an SVC obstruction? Would radiotherapy and urgent stenting be within their goals of care? Other reasons for dyspnea in palliative care, thinking about anemia, thinking about rhythm abnormalities, thinking about COPD and interstitial lung disease, heart failure, and also our MND patients. In a nutshell, we'll try to treat the underlying cause, but in palliative care, we often have problems that we can't reverse. Our non-pharmacological measures might include oxygen. If they're saturations are less than 90%. Handheld fans are of huge benefit to patients, and we need to really engage our allied health team, our OTs and our physios to help educate about positioning, pacing activity, using mobility aids, and learning about breathing techniques. If we think about pharmacological strategies, opioids are a first-line treatment for dyspnea. And in a patient who is opioid naive, we can get away with starting really small doses of morphine, 1 to 2.5 milligrams, 1 hourly as required, and counseling them to use it often before a planned activity. Take 20 minutes before a shower or planned exertion. If a patient, however, is not opioid naive and is already established on long-acting opioids, their usual breakthrough dose would be what we would be more recommending. And there is also a line to treat with benzodiazepines, as breathlessness can cause a lot of anxiety. And being quite cautious, I think, to begin with, 1 to 2 drops of clonazepam sublingually, 6 hours PRN, and I would very rarely prescribe the two together. So this has been a bit of a whirlwind whiz through a few common palliative care symptoms. I would, I'm not sure if there's some questions coming through the chat. I've been a little distracted to keep an eye on those. But I'd also really be interested in knowing if there's other things that you'd like me to cover in our next session.
Okay. So I just.
Yep.
Okay, so now everyone can hear me. Sorry about that. With a little few IT issues, but thank you, Olivia. That was an amazing presentation, and I'm still sure that everyone in the audience would have a lot to take away from that, and we will make Olivia's presentation available to you as well, and send that out to you by email. So thank you very much. At this point, I'd just like to ask all of you out there in the audience, if you do have any questions or comments for Olivia or for Julian, our palliative pharmacist, you're welcome to use the chat if you're feeling a little bit shy. But it would be even better if you are able to raise your hand and unmute yourself when we call upon you to let us know what you might want to ask or discuss.
I can see one question. Therese, thank you for asking me about some useful apps. I think Fiona, absolutely, PalliMeds and GP Pain Help and the PalliAge GP apps are really great. I do have another app which I think is fantastic, and it is called Palliative Medicine. And it has a bit of a sunrise in the background, and it was written by Dr. Graham Grove, who used to work in South Australia but now works in Queensland as a palliative medicine physician, and it is fantastic. And really, if you have a palliative care issue, there is a really neat and tidy guideline that is really accessible. Something that I use in my practice is one of the anesthetic college apps called, I'm just having a look on my phone, called Opioid Calculator, and that's what I always use to check my opioid conversions. And I think there was a question about talking about anorexia next time, and I agree. I think family members are often very distressed by their loved one losing weight, getting frailer, and I think it really speaks to the way that we often show love by wanting to feed and patients not being able to eat anymore. So absolutely, I'd love to speak about that next time.
Do we have any more questions? Tiff, can you see anyone with a hand up?
I was just going to quickly mention, Olivia spoke about Targin earlier. If you're prescribing Targin, just make sure it's available. There's a lot of stock shortages at the moment. So I'm sure all the GPs here know that because you've probably got phone calls from pharmacists like me saying, please switch. But it's a really important part of palliative care is that access, and we'll talk about it a bit later. But yeah, making sure that your pharmacy supplies the Targin is a really key element to making sure the person actually gets their medications.
Okay, so do you have, Olivia and Julian, do you have any more thoughts or comments that you would like to add before we move on? No? All good. So now that the didactic portion of this